Anand Vinekar sir is not only the torch bearer, but actually now a light giving sun in ROP. He is the main person, not only India and outside India also. It's an honor to have him in our session, coming from way long from Narayan Netralaya, Bangalore. He's a passionate and I have no words to say here for him. Sir, please, his talk is on how to propagate ROP awareness in your state.
Thank you, Anubhav, and thank you, KSOS. It's always a pleasure to come here into Kerala. Right, so I think Divya spoke about this. We are the highest number of preterms in the world, and there are a lot of reasons, and very importantly, I think the awareness in the neonatal community is very less. This is an impact paper that we put out about 10 years ago, and despite having wonderful care in healthcare, Kerala will still have a large number of babies who will turn blind if they are not screened on time, and I think this data is only increasing now because of improved neonatal care. So if you look at the incidence of ROP, earlier it was thought that it was going to happen only in urban areas, but our multicentric data in government rural areas has shown that it's almost comparable in the rural areas as well from Karnataka. A lot of my talk is based on this public health paper, which was published in the Lancet by 2 neonatologists. And that's from where we learn lessons from one of the most successful programs in the country, which is the polio eradication program. So steps on propagating it, I've been working closely with some other states, in fact with Kerala as well before COVID, where we had trained a few districts under the government. Something you need to have some sort of a leadership. So having a task force itself within the state, a core committee, or a Section 8 company, which is basically a not-for-profit company which can go out and look for funds. There are examples on how this can be done. There are charters with the National Task Force. We also have the Indian ROP Society, with both of them are members. And the best way to work to make it scalable is to work with the government, and that is with a public-private partnership. It's not simple. Every state has its own logistic issues, but that's the only way you can make an impact. For example, the special newborn care units, first thing you need to do is map out where they are, and that's relatively easy. The next thing is to map out where the ROP specialists are, and already if there are existing cameras. For example, there are already 7 existing cameras in the government setup already because they had purchased it in 2017 and 18. Here's a map of Uttar Pradesh. It's a very big state, 74 districts, 240 million population, but we're mapping it for them. They have a core committee. They're working on the lines of what I'm suggesting. And what you need to do is already map out who are the people who are doing the ROP screening, who are the ones who can do the treatment, and who are the ones who have the camera. After that, you can make a sort of a geographical model to see how they can move around within that geographical. Now, not all states are the same. You have hilly areas, you have flat areas. Kerala is longitudinally long. It's not very wide. And those are limitations that we have to understand when we make any geographical program. In Karnataka, for example, we have 6 teams that work through our 31 districts. So each team has roughly 5 districts. And we had started from 3 hospitals. We are now about 190. This is government and private. And all of these are covered by these 6 teams. So this is how you can maximize with just 6 cameras, 6 SUVs, and about 12 trained technicians. The next thing is you already have excellent people doing ROP, so you don't need to replace any of them with cameras. So you must have a 2-method model, either indirect ophthalmoscopy or imaging. So indirect ophthalmoscopy still has a lot of role, and I think except for the fact that there's medico-legal issues, which of course you can overcome, this is still one of the possibly the gold standards. And the only disadvantage is busy people like them who are also doing adult retina and not exclusively ROP are going to find it difficult to spread themselves thin. How many centers can you cover in a day, in a week, even if you are very good and passionate about it? So our model was, of course, to replace the so-called ROP specialists with non-physicians, trained technicians. So earlier we started with technicians, which is a vertical cadre. Then we started having optometrists, ophthalmic assistants, nurses. Then we started even training school dropouts. My point here is that anyone can be trained to do imaging because that works on pattern recognition. The next thing is to uniformize, homogenize the entire screening program. Now, a lot of you all will realize that even in Kerala, there'll be people who are treating differently. Not everyone's following all the guidelines at the same time. And that can become a problem when you transfer patients between yourselves or for that matter, medico-legally. Now, if you are worried, if the government is worried that, oh my God, what is this camera coming? You need to come, you need to do indirect. Well, India has become the first country in the world to allow screening by non-doctors. And this is the national guidelines. This is not mine or yours. So they have to be convinced, also medico-legally. So this is what we did. We have started training a lot of people who are from different cadres. And we showed that these technicians can not only be trained to image these babies, but also to grade these babies. And how you levelize these, how do you say what is the skill of these technicians to take these images also has been published and has been, more importantly, this work has been incorporated in the government guidelines. So you have a level 1 technician who has certain amount of accuracy and we know his limitations. Then you have a level 2, a level 3 and so on. And what this model shows, and again been published, is that if you have this image-based model which goes around while you all are busy doing the treatment, then you will see no stage 5. That's what we saw. When we started off, there were 18 stage 5s within 3 months from the rural areas, and now for 8 years consecutively in India, in Karnataka, we have 0 stage 5s from any screened center, especially from the government cadre. The disadvantage was, of course, the cost of the camera, which is when we started working with Indian industry to make it cheaper. The next thing is you have to work with your stakeholders, and those are of course the neonatologists, but also the nursing associations, optometrists and parents. Here are some examples of what we are doing, not just in Karnataka, but through the Indian ROP Society. So conducting workshops, awarenesses, instruction courses, and then holding more closed door meetings with the actual stakeholders. So if it is nurses in a nursing college, optometrists in the Ophthalmic Council of India, here's an example of what the Indian ROP Society is doing. Dr. Karobi is heading what's called the Ambassador Program, which is basically looking at optometrists and non-doctors, non-ophthalmologists, and we were trying to get a brand ambassador. You know, that's probably one of the reasons why polio worked, because they had Amitabh Bachchan's voice. Salman Khan became very close to becoming our ambassador, but did not. So we are still in the quest. I think having somebody like that, or maybe like a Deepika, will really help. But then also engaging the parents, and you all have an extremely educated force here. You know, yesterday in the cab driver driving me was telling me about the ISRO in Trivandrum, what all it has launched. This is unheard of in Karnataka. That's the level of knowledge your so-called normal laymen have, which means you need to cater to them. Now, when we started working with neonatologists, we were able to reduce the incidence of severe ROP from 80% to 30% in just 1 calendar year by allowing them to improve their own care. But this you have to do through the NNF. And then look at this captive audience. They are sitting there with their babies waiting to get dilated, and that's an excellent time. And we've been working with pediatrics department, with community department to improve breastfeeding, immunization, good neonatal care. All of this can be done while you are anyway screening. And counseling is so important, and this really helps if you are able to show them an image. Medical legal aspects. Convince your neonatology friends that they are responsible for any baby that within their care or within the care after they are discharged and they come back for immunization or whatever. The only time they may not be negligent is if they have documented that they have told them to come on time and they have not come on time. So contributory negligence, this is the case from there. And then of course uniform processes, whether it's the ICROP3, whether it's the national guidelines. Look at this. This is one of the court decisions which has used the operational guidelines in its judgment. So if you don't use the guidelines, the judges will. So this is something that you need to convince your neonatology friends. This is something that you will eventually need when you're making the entire program of the state under one admin level, which is why I thought you all should have a task force or through the KSOS. Why not? And right now you'll have a president who's also an ROP person, right? So why not? So this is a dashboard for that example. This dashboard will connect all the cameras or all the work. It's like a registry but online where all the images sit in one. This we've worked with Forest to develop. It was particularly developed for UP. These are demo images, that's why we didn't put retinal images. So it was developed for Uttar Pradesh, 74 districts, bigger population, so it's pretty much. So the person who operates it puts the diagnosis. The person who is in charge of that zone will see the image with a notification. You will agree or disagree with your technician. That will go back to the technician. If you're on leave, the next person who is in part of that ecosystem will get the message, so on and so forth. And this has been validated by business schools across the country. This is some work that Kidrop has been doing now. We are now in 10 states, and we are mentoring them and financing them through NGOs like Have a Heart Foundation. And this is one of the papers that my colleague will be presenting at the World ROP next week, and how to make it sustainable financially. So if you have a hybrid model where you can continue to do free screening and free treatment for government babies, you can still be financially viable if you charge your private patients, and that works as early as 2 to 3 years. Within 3 years, you can break off from your funding and be completely financially viable. These are some new innovations. This is a camera that's just being launched. This is a Nubo camera by Remedio. You've probably heard of Remedio's fundus on phone and so on. So this is going to be probably, we hope, at least half or one-third the cost of the Neo camera. They have not yet come out with the pricing. It's 130 degrees. They claim that it works in small pupil as well. And of course, then artificial intelligence. So as more and more of you start doing imaging, we now have a completely Government of India funded, BIRAC department funded AI algorithm that we have developed, and it's going to be absolutely free for any government system to use because it's funded by the government. This is our first publication. And unlike any other AI system in the world, currently the Americans have an AI system where they only can tell the plus disease, plus yes or no, vascular severity yes or no. But the Indian algorithm will be the first one to decide, to tell you whether there is disease also and plus also, and therefore refer, and refer how? Urgently, follow up, or completely normal. And we absolutely invite everyone, all of you, to participate in this validation because it's our model, our country's model. And then, of course, some other innovation in terms of tear biomarkers, where we're taking the tears of these babies and we're able to predict which of these babies will eventually get disease. Unfortunately, it's currently at a lab model level. To make it scalable to the community, we'll need to work a little more. But these are some of the publications. And look at this, telemedicine model, ours at least, worked continuously every single day of the lockdown. So this is the power of being able to do it. I want to end with this financial impact that you can make. If you're talking to a politician, the ROP numbers may seem less than glaucoma, diabetes, or cataract for sure. But if you can tell them the impact it can make, this is the formula you need to use. Number of babies you've treated into the per capita income into the life expectancy. And that's the crores of rupees that you can save just by doing this treatment on time. I'd like to thank everyone involved in this, especially KSOS and Anubhav for this opportunity, Dr. Mahesh sir, my own founder, my colleagues Snehal and Sushma, and of course all the babies over these 18-20 years who have put in the faith into our system. Thank you so much.
Thank you, sir. Thank you, Anand, sir. Anyone has any question to ask, sir? It's a great talk, sir. Really enlightening. Always, it's an honor to listen to your talks. Really a big honor. So next I'll invite, thank you, sir. Next I'll invite Dr. Divya Balakrishnan.
Can I have a question, please?
Pardon?
Can I have a question?
Yeah, please.
Sir, what percentage of babies with PAR, peripheral avascular retina, you treat? You treat all babies at 60 weeks, or?
Yes, by definition, PAR 2 disc diameters or more, as Anubhav said. The current guidelines that will come out of the Indian ROP Society is to wait at least to about 48 to 52 weeks. But if you are in a scenario where you can do these treatments under general anesthesia, you can wait up to 55 weeks, which is recommended by the NNF 2020 guidelines. After that, there are two disadvantages. Not the fact that the baby is big and difficult to treat, but the retina starts thinning out. Physiologically speaking, fovea develops by the 44th, 48th week. And for normal fovealization, you should have normal peripheral retinal vascularization. So if you are not providing peripheral vascularization by that time, waiting for 60, 70, 80 weeks is no use, because then you are only treating dead retina. But if you are able to treat with 70 milliwatts, 80 milliwatts of power with, not that intensive burns that we do for type 1 ROP, but just like an FEVR pattern, then you can actually promote vessels into that area at that correct time. Doing it like he showed, late recurrences have been reported and I've seen children who come to me as teenagers, who come from the pediatric ophthalmology department as myopes. And when you do an angio on them, they have active new vessels. And they've been injected 12 years back. So it's a very scary scenario. In the words of Michael Treacy, if you give anti-VEGF to ROP, you're converting it into a phenotype like FEVR. So the short answer to the question is yes, PAR should be treated. When you treat would depend on your scenario, your comfort of lasering a baby under topical anesthesia up to 4 or 5 kgs, or whether you're working in an institute that has pediatric anesthetists, then you can push it a little longer. So wait for the blood vessels to reach zone 2, and then after that you can treat. If there's a recurrence, of course, you'll treat earlier. And that's the advantage of using a bevacizumab over a ranibizumab, where you get at least 12 to 16 weeks after injection before you can encounter the PAR.
Okay, thank you.
What model do you think will be feasible?
Sir, do work.
Like Anubhav is screening around 17 hospitals.
Yes.
So like that,
So even in government hospitals, there is
There
what
is
sort
work,
of model
but that
use?
coordination is not happening.
Yeah.
I realized that when we were working with the Kerala government in 2018, that you all have excellent pockets in the government and private, but they were not working
Working
together.
together.
There is some, I mean, for the lack of a better word, some trust issues between the two. But I think this happens in every state, that the government is not allowed to send a baby to a private hospital if they have their own facility. But with the advent of public-private partnerships, with the mandate now from a Supreme Court that every system has to have a compulsory ROP program, and our, sir, that in 2015, that court case that happened in a tertiary care government institution in Chennai.
Yes.
After that, I think scenario has changed. My strong advice to you all, in some places, for example, this is being done in Madhya Pradesh, where the state ophthalmic society is taking the leadership. So they are making a representation. That's not happening in UP. In UP, we are forming a Section 8 company. But in MPOS, they are actually forming, as a state, the president and secretary are going and meeting the NHM and saying this is what we want to do. So these are different. If you all have classmates, batchmates who are IAS officers and who are in the healthcare, which usually I think ends up happening, this is a great starting point. The Karnataka model started simply because we had one IAS officer who was a woman who was completely convinced it can work, and she made it work. So I think it just needs that push.
Thank you, sir. And just one point to add to your question to peripheral avascular retina. In my experience in Kerala, what I feel is neonatologists are not very keen to give anesthesia to all these sick premature babies. So by that time, you can hold the baby, and if you are seeing avascular retina, whether it is having ridge or not, if the baby is more than 40 weeks or crossing 40 weeks, laser it off.
Correct.
Don't
so
wait.
I think with your comfort of doing topical lasers, 4.5, 5 kgs is not difficult if you have a good assistant holding. And that is typically 44 to 48 weeks. If you can cross 48, usually you have, so in fact there is a great paper from Tapas's group which shows what is a vascular arrest. 2 consecutive visits about 2 weeks apart where the vessels have not grown at all, then you can concur that this is not going to grow anymore, and that's a great time to intervene.
Thank you, sir.